We'll begin with the PG clinics for today because we have poster presentation soon after. We are going to have one long case and one short case for the day. I invite Dr. Dilip Mathai, the previous chairperson, to chair the session along with Dr. Vivek Matthew. Dr. Vivek Matthew is a professor in neurology in the Department of CMC and the previous head of the department as well. Thank you, sirs, for taking time out to do this clinic. I'll now invite Dr. John Roy. He's a postgraduate in the Department of Medicine to present today's long case.
Uh, Good evening. Today I'd like to present Mrs. B, a 37-year-old lady who used to work as a housemaid in Ludhiana, Punjab. Her chief complaints are progressive weakness of all four limbs with sensory symptoms for 15 months, difficulty in voiding urine for the last 2 months. So the first chief complaint, which is a progressive weakness of all four limbs, she was well until August 2023. She developed weakness first in the right upper limb. So she found it very difficult to screw open or close bottle caps. She was unable to tie the string of her pants. She was unable to tear roti, and her daughter had to break it for her, and she had to eat it like that. When she was threading needles, she was unable to grip fine objects. So that's how it started out as a distal onset. Subsequently, over the next few weeks, she was unable to hold the weight of a glass of water. She was unable to lift the mug for bathing. She was not able to sweep with a broom, and she found it difficult to lift her arms overhead while bathing or opening the door. Uh, Again, 1 month after this, she developed weakness of the right lower limb, which started out as slippage of slippers from the right foot with preserved awareness. She was aware when the footwear was coming off, and she found that she was frequently tripping while walking on uneven surfaces. And when she walked, she was dragging her right lower limb. There was a heaviness, and she was dragging it while walking. Subsequently, it progressed to buckling of the knee to the extent that in order to actually get up and walk, she needed the help of another person. She was unable to get up from a sitting posture, and she was also unable to use her Indian toilet because after squatting down. By May 2024, so over the next 4 months, there's a typing error. It's the left upper limb that was involved in a similar pattern with progression over a few months. Then again, between June 2024 and July 2024, she noticed inability to move the right lower limb. At that point of time, she also noticed that she was unable to move sideways in the bed, unable to get up from lying down position, and she's been fully bedbound since then. She says that this is all associated with tightness of all four limbs, which has been progressively increasing, tightness and stiffness of all four limbs. There's no history of muscle twitching, sudden involuntary flex.
Yeah, thanks. Very good history. But now you have to live the life of a physician who saw the patient May 2023 when she came to you with some disability in using the right limb. What would have been your thought process then? Because coming so late is difficult, is different. So you're a young physician who saw the patient in Punjab, Ludhiana. What would you think?
Since her initial complaints were distal movements of the right upper limb.
Okay. You will say some motor. By the way, when you say weakness, always add a word motor weakness. Okay. So you will say the person has got motor weakness, right upper limb.
Yes.
What will go through your mind?
I would try to localize it along the neuroaxis. So I would start from the muscle, neuromuscular junction, nerve.
Okay. It could have been median nerve.
Yes.
How would you distinguish it?
There would be both involvement of sensory and
Yeah, so you must re-emphasize that there was no sensory symptoms.
Yes.
You understand? It could have been anything to do with myopathy. Yes. How would you answer that question?
if it was a myopathy, on examination,
No examination,
on
symptoms,
history.
Because 58% of all diagnosis in neurology should be made from history. 40% or 35% from examination. So from the history, what would you think in terms of this monoparesis? I'm saying, I'm thinking of a lesion in the cortex. How will you sort it out? I'm saying it could have been a lesion in the plexus. That you answered. No sensory symptoms.
So,
Okay. Now, you also said that there is no pain or shooting pain. So you said that there is no radicular type of pain.
yes,
Okay. So now what is the next level? It is a monoparesis. Where is the level then?
could be cord, could be
It is, God
in
is
brains.
not there, na? Above.
cortex.
Cortex. You understand?
Yes.
So how will you rule it out? This is right-sided.
If it's a cortical lesion, the tightness and what she described would explain the cortical lesion.
Yeah. So
I
you
would
must,
keep that
you
under
must think
consideration.
of being a physician at that time, not when the disease is fully evolved to this bedridden state. Okay. So you've got some understanding now. Okay. Now, what is your diagnosis at the end of history?
At this,
This patient. Now,
yes, sir.
weakness on the right side, weakness on the left side, weakness in the right lower limb, weakness in the left lower limb, to a stage of being bedridden, cannot walk. Don't go for the bladder.
Yes, sir. If it was just pure motor, I would think of muscle, neuromuscular junction,
You will
anterior horn
think
cell.
of muscles.
Muscle,
One. Second,
neuromuscular junction, anterior horn cell.
pardon?
Neuromuscular junction and anterior horn cell.
No, neuromuscular you cannot, because
No effect.
the face you said is clear, na? From your history.
Yes,
So you will think in terms of muscle.
yes, sir.
So you will think in terms of what? Myopathy.
Yes, sir.
Why won't you think, okay, what prevents you from saying it is a problem of myopathy?
The fact that it's not pure motor, there
From
are
the history. Because myopathy will not develop like this.
distal to proximal
It will
is
be
unlike
bilateral. It will be present in whatever is the working condition is there for the lower limb and upper limb. We are not interested in the history of genetics and other things.
since it's asymmetric.
Yeah. So you have to look at, it's unlikely to be a myopathy.
Yes, sir.
So it's more likely to be a neurological problem affecting the motor roots.
So,
Which root? Anterior root or posterior root?
anterior root, sir.
Anterior. You understand?
Yes.
So you will say it is affecting the anterior roots. And on the left side, anterior root.
Anterior root.
It's not peripheral nerve.
Yes, sir.
You understand?
Yes, sir.
So in the lower limb,
Again, anterior root.
that's
That would
what
explain
you
all.
decide.
Yes, sir.
Is it a problem of the cord or is it a problem of the motor root? How will you decide? Because you're talking about a patient with a quadriparesis.
The bladder would tell me that it's cord.
Now you're bringing in bladder.
Yes, sir.
You understand? Because we know she's already catheterized.
Yes, sir.
So now, what is your diagnosis? Always make a functional diagnosis, then anatomical diagnosis, then pathological diagnosis, then etiological diagnosis. So at this stage, you should make a functional diagnosis. Sir, I am presenting a case of
Quadriparesis.
quadriparesis with predominantly affecting what?
Distal muscle.
Affecting what structure of the CNS or peripheral nervous system?
Cord, sir.
Affecting
This is
the
spinal
cord,
Yes, sir.
definitely. Why?
because of the involvement of the bladder.
Bladder. Somewhere.
Yes.
Second, definitely affecting the anterior horn cells or anterior root. Because it is
Anterior.
not, it's anterior root, posterior root, you said sensation is normal. It's not the mixed spinal nerve because sensation is normal. According to you, presentation, history.
Yes. So just to clarify the sense.
Don't worry, history level. Because if you don't form a diagnosis in the first 5 minutes of the exam hall, forget it, you're not going to make it. The etiological diagnosis, the structural functional diagnosis on this patient is quadriparesis, period. Well, now, what is the quadriparesis due to? Definitely in the lower limb is talking in terms of cord. Definitely the bladder is talking in terms of the cord. And the upper limb is talking about the motor roots, anterior horn cell roots going to the small muscle. So what you will do, I have not seen this case. Immediately I will open the palm. Is there any wasting?
There is wasting.
If there is wasting, you got your root number. What is your root number?
C8T1.
So if it is C8T1, which hand?
Sir,
C8T1, na?
right hand, yes, sir. Yes,
right hand.
right,
Yeah.
C8. Yes, sir.
To demonstrate that. You got your diagnosis, C8T1. You understand? So something is compressing. Now we got it on the left side. How did it come to the left side? So whatever it is, I'm not talking about extradural. I'm not talking about extramedullary, intramedullary right now. All that we are saying is the root is affected. What is the problem on the left side?
Progressive weakness again, similar weakness.
Pardon? No. Anterior roots?
Cord only, sir. Cord again.
Anterior root or no root?
Anterior root.
So if you say the word anterior root, it has to be lobomotor neuron. So you, right side, we said lobomotor neuron because you got wasting. Left side?
Left side also there is wasting in the hands.
Are you convinced?
There is definite wasting, sir.
So if you say, I've got bilateral wasting, okay, and then what is happening now? Where should the lesion be?
Anterior root as of.
Anterior roots affecting C8T1, I don't know, 5, 6, 7. You understand? So you've got your level. Now what do you want next step? You got your uppermost level, you want your next lowermost level. You understand? So where do you think the level is? What are your cord symptoms now?
So, the other symptoms, sir.
No presentation. You have spent time now. Then we will open it out to them.
Sure, sir.
Think. What is your cord symptom? Bladder.
Yes, sir.
What is it, bladder? Dribbling? Did they put it? Or inflow, overflow, incontinence? Don't go into high funda bladder problem. Just think why they put the catheter.
So her complaints were urgency, frequency, hesitancy.
Okay, what you are saying, either overflow or bladder, she could not pass urine, or they brought her here to the exam hall. They didn't want to wet it. You understand? Or it's maybe because of lower second lesion there. That is your only problem. Why do you want to examine the patient? You already got the diagnosis that this is a quadriplegia when at the level of C8T1, and you've got a paralysis of the cord being affected. So why do you want to examine the patient? So I want to examine the patient to confirm my diagnosis. So how do you confirm your diagnosis? Which reflex will be absent? Upper limb.
For a cord, sir.
You got your localized lesion now.
Yes.
Is it at C81
Yes, sir.
or above C81?
If it's at CAT1, the brachioradialis, not the brachioradialis, the finger flexors would be.
Okay, deltoid, you don't spend too much time. C5, you can't tell too much, but you look for fasciculations. If you don't find fasciculations, axillary nerve, leave it for the moment. So then what about your biceps?
Biceps are exaggerated in hers.
Biceps are exaggerated. Left side.
Exaggerated, sir.
So where is the lesion?
Above
What
C,
lesion?
above C5, C6.
Above?
C5, C6.
Above C5. Or okay, or at C5 or above C5. Because C5 you cannot test. Okay, above C5. What about your brachioradialis? Absent or present?
Present, sir, and it's exaggerated.
Exaggerated. And your finger flexion?
Exaggerated, sir.
So all these correspond to a lesion above C5. At C5, I'm not too sure. I have to examine. Now you go to your lower limb. All the reflexes will be
Yes, sir.
with plantar Babinski being positive. So why you want to waste your time? Inspection, from the history you make your diagnosis, and from your examination you confirm it. The best investigation for a neurological case is what? Not CT scan, not MRI, repeat examination. So if you've got 15 minutes for the exam, take the history, get the localization of the lesion, do a focused examination, write down. So this is my functional diagnosis, quadriparesis, structural diagnosis, roots being affected. See, I don't know where it is, 7 and 8, definitely there because of wasting. And the cord is affected above C5 or at C5, I'm not too sure. Finished. Cause of the lesion, now you decide. Pathogenesis. Yesterday I was telling you, gradually progressing. Anything that is gradually progressing is compressive. You understand? Now, can it be degenerative? Yes, it could be. That's all you can say. It is not vascular. Now, if it is compressive, now you have to decide whether it is extramedullary or intramedullary from your symptoms.
Because the bladder is late, I would think of extramedullary.
Okay, you have established 12. It started in August 2020, May 2023. Then in August 2024, she developed the bladder. So bladder came out late. Today you cannot say, okay, now the question will be, since the bladder has come out late, what has been affected? If the bladder is coming out late, it is the corticospinal tract that is affected. And where are the bladder fibers arranged? The bladder fibers are arranged in the trans-equatorial. You have a board here? No. In the trans-equatorial plane, just in front of the corticospinal tract. So the bladder fibers are affected. Surely the corticospinal tract fibers would be affected. Otherwise, how will the bladder fibers? And that is how this progression. Now you tell me about the arrangement of the fibers, tracts in the corticospinal tract. What is most lateral?
Sacral, sir.
Pardon?
Sacral.
Sacral. Then lumbar. Then thoracic. Then cervical. You understand? That is how your left leg and your right leg got affected. And that is affectation is because of your tract. And 100% sure you will not see any wasting in the lower limb. If you do see, it is disuse. You will not see any fasciculation. Yes or no?
No, sir.
You understand? But in particular, please have a look at the sole of the foot, S1, S2, because bladder fibers are also there. So you want to make sure that there is no lobomotor neuron lesion of the bladder, because you don't know why she's catheterized. I will sell myself to go and see the sole of the foot with no wasting. Okay, so now shall we summarize? Then you make your presentation. Began with weakness of the left upper limb, then weakness of the right upper limb, weakness of the left upper limb, then right lower limb, and left. What is this circuit called? What is this circuit called? Starts with E. It doesn't have a D. D is for the lip. Double L, both for love. Ellsberg circuit. Very good. Speak out loudly. Ellsberg circuit, which is so very classical of an extramedullary lesion. You understand?
Yes, sir.
Now, having said this, why do you want to examine the patient? What have I not got now? Sir, I have not got the upper level. I don't know what the upper level is. You understand? How will you know what the upper level is? What test will you do to get the upper level?
I would examine reflexes, sensory, and motor. These,
Yeah,
and then
all are above. No? What is the next step? So you come up to C5, C4 you cannot check, diaphragm you cannot check, C4, C5 you cannot check. C1 sensation in the occipital region, suboccipital triangle, maybe. So what does C2, C3, C4 unsolved cervicalis supply? Which muscle? It's very difficult to examine those strap muscles. Now you go next to the cranial nerves. 12. Can she lift the head? Oh, she's got collar.
so
Why?
she's got a cervical
Oh, okay.
operation done.
But then we won't. Difficult. Lift the neck. Okay? Or sternocleidomastoid. So the sternocleidomastoid is affected or not affected?
So the sternocleidomastoid is not affected, sir.
Not to the best of your
Yes, sir.
ability.
Yes, sir.
Okay. So now, I don't want you to check that. Now, tongue. Hypoglossal.
Yes.
C12. Cranial nerve 12. How much? Any wasting?
No, sir. No.
No wasting. What is the earliest sign of the wasting? How do you look for wasting of the tongue? Let me tell you this. The wrinkling of the mucosa of the tongue. Why? The only muscle, the site of origin is from soft tissue, and site of insertion is soft tissue, skin. So if there is wasting of the genioglossus, you will find wrinkling of the mucosa of the tongue. Don't look for left, right. So if C12 is not, T12, that is cranial nerve 12 is not affected. Of course, 11 is just for you to check, but 12 is not affected. Then you know, where will you say the lesion is? Above C5. Clear? So functional diagnosis, quadriple paresis, anatomical diagnosis at the level of C5, root. No, root is C8, T1. C6, no, because there is reflexes are brisk. So cord is affected there. You understand? So above C5, cord is affected. Lower roots, C8, T1 affected. So he has got an extramedullary compressive lesion in the region of C5 region or C6 region. Okay, resulting in this quadriparesis. There won't be any other findings, and I will not be wrong. I have not seen the case. Now, subtle things I will ask. If you want to get D for Dilip or D plus in the university, is there honors? Did you check for honors?
Honors is not.
Why
there,
did
sir.
you check for honors?
High cervical lesions could have affected.
Very good. high cervical region. Now I will ask you, why do you get horniness in a high cervical region?
Because the
Okay, so where does the autonomic nerve come from? So it's a craniosacral outflow. So which cranial nerve and what is affected? Which nerve? Which are the
hypoglossal,
nerves, roots?
hypoglossal.
Hypoglossal.
No. But the contribution to the
you get
answer
hormones.
cervicals.
Horns, na? Cervical sympathetic, na? 2, 3, 4
So,
will form together and supply the cervical ganglia, superior cervical ganglia. So the superior cervical ganglia supplies the, which one? Pupils, na? Oculomotor nerve pupils. So you will see if there is any horniness characterized by meiosis or mydriasis. Pardon?
meiosis.
Meiosis. Has she got meiosis?
No, sir.
No. Has she got sweating?
No, sir. No.
All okay? Then that's all there is. Now now you present your case. If there is any deviation from this, you have to explain. Okay? Yes or no?
Yes, sir.
Proceed. Any other comments you have? Because you have to make the diagnosis in the first 5 minutes. Otherwise, you will be going here and there. Now you go and sit down, take a pencil, paper. Right. I would say you start writing with a pencil diagnosis. Anatomical, sorry, functional, anatomical, at least I'll give you 2 marks, 10 marks for diagnosis, 10 marks for history, 10 marks for findings, 10 marks for discussion, and 10 marks for your overall appearance, how you handle. I may ask you, demonstrate certain signs. That's all there is. If you take 45 minutes to present your history, you will get 0 and 10. You understand? That is how you should focus for the exam and in life also. Okay, now you present. Now, why you are asking this question? Don't diurnal variation, fluctuation of weakness. You tell me why.
That is for neuromuscular junction. To rule out neuro.
Why?
It's not needed.
Not required. Diurnal variation for what? You will say maybe in the muscle disease. That's why I stopped you. I'm a kind examiner. I'm a very kind examiner, but a ruthless trainer. I make my postgraduates work 25 hours a day, 8 days a week. Tell the labor people, you're on stipend, not on salary. You understand? But very kind. I stopped immediately because I may lead him differently. He may go little different. You understand? Because diurnal variation is only seen in muscle. So I was worried he's going into muscle. You understand? Because of myasthenia, I was thinking whether he's going in that line. Otherwise, why? Fluctuation of weakness. Why? Okay, next.
So the first chief complaint was progressive weakness of all 4 limbs. The second chief complaint was progressive sensory symptoms.
Tingling sensation in the digits of the right limb.
Yes, sir.
Okay. Followed by numbness in the form of reduced. How patient is saying?
Yes, sir. She was not able to feel her clothes.
Okay.
She's not
This
able to.
progressively increase.
Yes, sir.
Reports induced sensation of clothes or insect bite. All these insect bite have. How many mosquitoes have you killed? These are all just fabricated questions. You are asking people, insect bitten you? Okay. So report sensation of clothes. Felt or not felt?
She does not feel. She was not feeling it at that
Well,
point.
was not able to differentiate between hot and cold. Impossible. Okay, she's from Punjab. Hot water bath or cold water bath? Or if you're putting tea finger, you're putting. How are you asking? How are you saying this patient is not able to differentiate hot and cold? Give an example. This patient, how did she say, sir, I don't know whether it's hot water or cold. Okay. When we check for cold and heat, we check temperature must be 7 degrees above normal or 7 degrees below normal body temperature. Then I can feel it. So 35.4 or whatever it is, that's why we checked 42 degree centigrade and cold water 35 minus 7, 27 degrees. You don't need ice cold water. That is the difference only. Okay, please be careful when you use that word. You just say, I cold and heat. She's able to feel or not able to feel. When I asked her, she said no. But if she says yes, then you go for specifics. Because I'm expecting a symmetrical lesion. So if I pour water here, it will go on both sides. You understand? Okay. Subsequently involve the right lower limb. Very good. Okay. This is what? No history of unsteadiness while walking in the dark. Yesterday we had this case. Unsteadiness while walking in the dark or imbalance while washing face or closing eyes. What are you trying to say?
I'm trying to say that the posterior column is.
Pardon?
The posterior column was not affected, at least
Please
historically.
remember this. Nobody in the world can check for cerebellar signs in the presence of motor deficit. Impossible. So if the person has got unsteadiness as a result of motor weakness, how are you going to differentiate it from cerebellar? You understand? It's nice for you to ask the question, for you to answer, but don't sell yourself on it as a high payoff question. If you sell yourself, if he says, customer difficulty high, it can be because of motor weakness. Okay, so now there is some change that there's some tingling numbness of the upper lip. Now, how do you ask the patient radicular pain? आपको हिंदी मालूम है?
Yes, sir.
कैसा पूछेंगे radicular pain?
आपको हाथों में झटका जैसा दर्द, शॉक जैसा दर्द
Ah, shock like this. So very high payoff question. If he has got it, you got the level of lesion. Jing. Baliverda. Allah kai tu customer are you taking any tablets for that pain? No. Which is the most painful condition in the world? Neuropathic pain. Steve Jobs said what type of pain? Neuropathic pain. Because of the splanchnic nerves being affected. It is not delivery pain, not myometrial pain, not cramps, but neuropathic pain. No history of pain worsening on sneezing or coughing. Very good. Why?
In a radicular type of
You
pain.
are asking double question. Radicular pain first. Okay, I want to finesse, fine tune it. I ask for cough and sneezing. Very good. No history to suggest suspended sensory loss. I don't know what that is, how you translate that to
Yes, sir.
patient.
So I asked them whether did they feel that there was less sensation involving the arms and the.
Okay, you're thinking of syringomyelia?
Yes, sir, like a.
Okay,
central-
no problem. But it's difficult to ask that question. You understand? But when you check it out for the loss, then you say, go backwards. This is cheating method. Once you find syringomyelia, then you cheat all this. Like yesterday, you had that patient with high pulse pressure. Once you get the BP reading, you know it's high blood pressure. Then you do cheating method. There what are the 10 causes of collapsing pulse? Don't go for all the collapsing pulse, but they got this and that, you'll waste your time. You understand? So this okay. Lermet's symptom or Hermit's sign or Hermit's symptom.
I asked her when she flexed her neck, did she have an
You
electric?
should never do this. You can ask for any pain going down your spine, but don't ever try to elicit Hermit's to see if there is pain, because you can cause cord transaction. So Hermit's symptom or pain going around the spine is a good question to ask, which will tell you about extramedullary compression. Very good. Next.
Any band-like sensation?
Band-like sensation only if it is in the
Thoracic.
trunk. The equivalent of band-like sensation is radicular pain. Band-like sensation is nothing but radicular pain. Okay, next.
The third chief complaint was
Very good.
difficult.
Increased frequency, volume, Don't get lost in the bladder now.
Yes.
Okay. Later on, we can go to that. We'll come to the bladder. Rajiv will talk about the bladder. Next one.
All
No.
negative history,
Okay.
sir.
Now, what is it you're trying to say?
I'm trying to rule out all the other.
You are giving relevant negative for higher functions, relevant negatives in symptoms for cranial nerves. Because you have finished cranial, you have finished everything else, motor, skeletal, everything you have finished. So he's trying to say there's nothing wrong in the central nervous system. Because what is the cause? But usually seen with paraparesis, not seen with quadriparesis. Cortical lesion, if you've got a hydrocephalus, you can get paraparesis plus bladder affectation. So it's nice to finish off, round off by saying, I don't have any problems related to the higher functions, related to the cranial nerves. Don't go for too many.
Yes, sir.
How many symptoms are there in the body? More than 800. How many do I teach medical students? 136. How many are there in central nervous system? 39. How many are there in respiratory? 13. 7. How many are there in cardiovascular? 13. So if you want to say no of central nervous system, you can go one whole day. So relevant. Cranial nerves, you just say no change or difference in the sensations of the face. No difficulty in speech, no difficulty in swallowing. Don't go for all the features of cranial nerve. You cannot ask hearing loss. You can ask them, but very limited, because you don't know where the highest level is. So cranial nerves is a must, higher functions is a must. Then anything else? No injury. Just say no history of any trauma. Why you're going in for cough and fever? Okay, respiratory system, no
TB of this.
nutrition. Then no. Finish the systems first.
Yes.
How many systems are there in the body? 7. What are the systems? Central nervous system, cardiovascular system, respiratory system, musculoskeletal system, and the remainder 3 are in the abdomen. What are the 3 in the abdomen? Gastrointestinal system, including liver and pancreas. Then hematological and reticular system. And the 7th one is genitourinary system, including the kidney. Don't go and tell dermatology. Dermatology is not a symptom. Doesn't have it's a system. Don't go and tell Nihal Thomas, endocrinology is not a system. All the manifestations of endocrinology will be seen in all of the above. You understand? So take relevant symptoms from each of these systems and say no. Mixed diet, no high-risk sexual behavior. Okay, it's all right. Because I'll tell you, to ask for a sexual history, you need closed chambers, 40 minutes, 30 minutes, anakana, every day. Because to ask somebody any exposure to sunlight, moonlight, or rain, it's very difficult. Okay, be very careful when you ask. But if we teach you, take sexual history, you have not taken sexual history, finito. Menstrual history?
Sir, I had
How many
asked
children? Go.
2 children,
back.
sir.
Menstrual history is very important.
Yes.
That's why I said respiratory, genitourinary include. No other, 1.5 years, no other hospital admissions. In Punjab, Punjab is a rich state. Be very careful. Don't worry. Underwent CMC October 24. Some improvement in weakness and sensory deficits following this. Okay. Okay. Summarizing. Slowly progressive, asymmetrical onset. How can you say spastic?
Tightness of.
On history.
She says tightness of all 4 limbs.
You cannot say spastic unless you say, I got Myclone, I've got spastic, uh, you've got, what, huh? Yeah, plexus spasms. You cannot say. Predominant motor weakness of all four limbs. Don't say that. Which is more? With sensory symptoms below the neck, don't say. Level. Okay, approximate level, the neck. How do you know upper motor neuron type of bladder? Don't commit yourself with a bladder involvement. No involvement of CNS.
Cranial nerve,
Cranial nerve.
cerebellum, etc.
Cerebellum, don't say. Don't say, don't say, don't say. After examination, you can say, because you have not asked for cerebellar symptoms. You understand? You have not, what is APS?
Extrapyramidal symptoms.
Extrapyramidal. Don't ask, because only that's a, nobody will say I'm having rigidity. Okay, and higher mental, don't say higher mental functional, no involvement as such. Okay, yeah, proceed. Sorry, you want to say anything?
You can finish the history, and then I'll say. Go ahead. I'll stop you in a little while.
Shall I go on to examination, sir?
No,
or-
no, you
Yeah.
summarize your history.
Yeah. So, yes, sir.
What?
Yes, sir.
Yes.
Yes, sir. Historically,
Saying forward. Don't go into the specifics of the cord. After examination, you say. Okay, very good. Up to here, history, you have understood the case. So I will give you 8 on 10. If I am the examiner, I'll give you 8 on 10 because you have not misled. And none of your statements are, very violent or violating any principles. Now we'll see on examination. Proceed.
Okay, then I'll take a quick summary. Okay, so for what sir has given over here is an excellent method of a clinical method. So a few things I just want to make sure that all of you have gotten this right. So history, of course, is you have to break down in anatomical terms, functional, anatomical, localization, and then etiology. History gives us the diagnosis, and just to make sure that everybody has got sir's message, it's a mathematical approach, and we have to develop a hypothesis. What sir did was immediately within the first few sentences, he had a hypothesis, and then he was asking why not, the various levels of the neuraxis, and then you have to think ahead that what do you expect if this part of the anatomy, this also should be there, or this should not be there, and so that's how you go about it. Give all the positive symptoms first. You started with motor, and then you started giving some negative history of motor, and then you went to sensory. You don't need to do that. And a relevant negative, we have to be very specific about that. And in history, you have to give examples of actual situations, like sir really pointed out well, and avoid too many leading questions which have low interpretability. So just keep that in mind. So, and the examination, what you're going to do is now is just quickly confirming your diagnosis. That's about it. So let's go through it.
vitals were stable, sir. Just the positive features on the general examination. She had a bald tongue. There was gingivitis. She has a vertical midline scar of 4 centimeters in the nape of the neck. There's a healed sacral pressure sore, and she's had a tracheostomy, and it's decannulated. She's got a post-tracheostomy site wound. There's no other general examination was normal. There's no
Why
hyperpigmentation.
does she need a tracheostomy?
Uh,
There's nothing on the history to suggest.
Yes, sir.
that.
This was during the immediate post-op period that she was higher mental function, sir. She is alert. She's oriented.
Yeah, no. You are correct in saying measurement of head-neck ratio. But what are you trying to say? You're trying to say whether this person has got a short neck, or you're trying to say whether it is, we won't come to that level of thinking, but it's a short neck. So what do you look for short neck? You look for C7 vertebra. Okay, C7 vertebra, the hairline should not be below C7. Okay, that is one. Otherwise, it's very difficult for you to measure the, uh, the neck, that what you have measured. Others, how else will you measure? Only for the C7 vertebra. Sometimes the people say low set ears as also a feature. How do you know the ear is low set? So you draw a line from the outer canthus and the helix of the ear should be below it. If it is below it, it is low set ears. How do you say it's got high arched palate? So difficult to see high arched palate. Open the mouth, I cannot see the roof of the palate. These are all difficult things, but you can still say that the neck appears to be short compared to the torso. Okay, next.
So the higher mental function and the cranial nerves were
Okay.
normal.
I am just digressing for 1 minute, but pardon me for this digression. I find that when you get a when you get a cardiovascular case, when you see an abdomen case, or when you see a respiratory case, nobody does a CNS examination. Even in practice, CNS NAD, without even touching. Why are you scared of examining the CNS? If I do not have any CNS symptoms, don't worry. I will teach you this 3-minute neurological examination. Just 3 minutes. But please do it. First and foremost is Porla. 30 seconds. Pupils equal reacting to light and accommodation. When I ask students why you have not done, sir, I didn't bring my pen torch. Some people bring pen torch, but sir, no battery is there. Why all that? Porla. Second one is EOMI, external ocular movements intact. Period. You have taken care of the brainstem because brainstem is a silent area. Don't ask for higher functions. Don't worry. Why will I come to you if I'm having an abnormal function? Don't ask for higher functions. Speech, I'm telling you, sir, only. Why do you want to waste your time? So half a minute. Motor system, don't. I'm walking and coming to you. I have no neurological problem. Sensations, also I will tell you, but you have to quickly do. Then reflexes. At least you do knee jerk and ankle jerk, upper limb biceps or radial. Do the Babinski. Half a minute, 2 minutes over. Then what else you want to do? Vibration cells. Lower limb, you do vibration cells. Tuning fork, whatever you are using, 526 or whatever, okay, use that tuning fork. That's enough. Crude is enough. And how do you check for pain? Don't take your hairpin. Don't take your pin. Take a toothpick. Not what you have put in the tooth, but toothpick fresh. And check. 4 areas. Sensations intact. So vibration sense you got. Babinski you got. Then light touch. 3 minutes. The other half a minute is for fundus. Forget it. Don't do fundus. And if you have honestly not done CNS, I write not done. I write reflexes not checked. When I get time, I will check. But don't write NAD. Please, in medicine, don't falsify record. Because I'm hoping that someone else will come and check it. But if Dilip Matai writes CNS NAD, nobody will check. Don't do that. Okay, so that's a 3-minute neurological examination. Every patient, you try to do that. Don't check for muscle strength. Don't check for coordination. Nothing. Okay, having said this, why you're going into such details? Very good. Visual field. That's all. Very quickly. Okay. Fundoscopy, normal. Don't sell yourself in this. High payoff findings. Where do we want? Lower. Where is your 12th nerve?
Yes, sir.
Normal. Here you write no fasciculations, no wrinkling of the mucosa. 11th also you can write. Gag intact. You will have central. Okay. Why you want to do whisper test? If the person can hear, leave it alone. Don't do Renis, don't do Webers. Just if the person can hear, don't do Renis, don't do Webers, nothing. Now, why did you go for jaw jerk?
Uh, because if the jaw jerk was exaggerated, I would think of
No,
something
no, no, no.
about
What
the.
you're doing for jaw jerk? It's a higher function. Na? It's a what you're trying to see if there is a multiple jaw jerk is normally present. If it's not present, don't worry. But don't write not exaggerated. That means you're telling it is not above fifth cranial nerve, not above midbrain. Because C5 jaw jerk is what is the okay? What is the afferent for jaw jerk?
Fifth cranial nerves.
What is the efferent?
Seventh, sir.
What is the center?
The fifth nucleus, the
Pons.
pons.
So every reflex they will ask you afferent, center. So why are you going to the pons level? Because we are not in the pons level. No problem. Okay, gag intact. Next. Oh, why that emotional lability? Why?
So because this is a case of quadriparesis, if it's a bilateral cerebral hemisphere.
So get D plus. Okay, but if they ask you, you have to explain.
So,
Okay, next. Very good. Bulk. Acha, yesterday also people are measuring. I don't know what is my strength. I don't know. Why are you measuring arm girth unless you know there is a difference? Is there any difference?
no, sir, no significant difference, sir.
Now you can say, if I don't measure, sir, how will I know difference? You understand? Don't go into ecstasy 29.5 like a tailor. 29.5, 26.2. Do you observe? If you don't observe, it's all right because it takes time. Medial epicondyle, radial styloid.
No, sir, those are just the bony landmarks that I use.
One minute. You take a bony point 6 inches above. You measure the bulk of the muscle, not the tendon. So 10 centimeters above the medial condyle, 5 centimeters, whatever you want to say. Medial AS, IS.
Anterior
You have to take
relax.
always bulk of the muscle. Anyway, atrophy of the thenar and hypothenar. What do you mean false localizing sign?
So I was trying to explain.
Do not make an interpretation at the level of clinical findings. If you want to make an interpretation, see, examination consists of observation, interpretation, synthesis. In the examination, what you're doing is only observation. Don't synthesize at the level of examination. You will go wrong. Next. Tone, upper limb.
Spastic all throughout, sir.
Don't say spastic. Increased. Now, what do you mean? What is the definition of tone?
Tone is the resistance that the muscle offers to passive movement.
Resistance offered by the resting muscle to sudden passive movement. Tone is measured over the joints. Okay, we will come to how you're going to. You just say tone is increased. Okay, if you want, we can say spastic later. Next. Of the joints only you can say. Go back. So you cannot say right upper limb over the joints. Okay, next.
This is the power examination, sir.
Okay, shoulder. This is
The
motor.
yes, sir.
Very good.
So it's an asymmetric involvement.
It is asymmetrical.
Yes, sir.
More on the right side.
Yes, sir. Distal more than proximal.
You got flexion 5, elbow extension 5.
No, sir. I didn't get 5 in any.
I will go and check it. Because if you're saying 5, other one is abduction, shoulder abduction. Adduction is what? Supraspinatus, infraspinatus. The nerves are coming from the cord directly, not from the brachial or from the brachial plexus. The supraspinatus, infraspinatus are all supplied from the brachial plexus. So you have to be a little careful. Okay, doesn't matter. Hand grip.
She was not able to grip the hand, sir.
Is weak, you're saying.
Weak,
okay,
sir.
then flexion, extension, dorsiflexion. So left is smooth. So there is disproportionate. We may have to check and you will have to explain. Because if you say that somebody is about 3, why she cannot walk? Hip and extension is 2. You have to be a little careful on that. Okay, next.
Reflex.
Exaggerate. Trapezius. How you do trapezius?
Right.
See, now please remember, trapezius has got no tendon you can tap on. Trapezius is a muscle, and that is myotactic reflex is different from the deep tendon reflex. So there is no reflex of trapezius. Okay, I'm just saying biceps, bicoradialis, triceps, knee jerk, clonus, plantar reflex, abdominal reflex absent. Why you're bringing corneal reflex here?
I was-
Corneal reflex must be under cranial nerve. It doesn't make sense here because you're doing this for localization. Okay, next. Sensory system below the pain and temperature reduced below both sides. Both sides.
Yes, sir.
Joint position sense impaired in both fingers, ankle, knee, wrist, elbow.
Yes, sir.
Okay. That's a very crude joint. Proprioception in that is vibration sense impaired. Yes, pulp of the finger, no. You cannot check vibration on soft tissue. Bone, what you're talking about,
Yes, sir.
okay? First metatarsal. Finger, inferior end of radius, whatever, or the styloid process.
Yes, sir.
Vibration over spine, don't say decreased, absent or present.
So I was not, the finding was not very consistent. I
Okay,
was
no
not sure
problem.
about.
Now, this is difficult. No perianal sensory loss. Now, what is he trying to say? We will discuss that later. What he is saying is that he has checked the sensation around the perineal, which is S2, 3, 4. Sometimes you will, if you want to be for quadriplegia, for paraplegia, yes, do a rectal examination and see the sphincter tone and see if the anal sphincter is there. For quadriplegia, not so much, but he's trying to prove a point. Next. No, don't say cerebellum, coordination.
Yes.
Because cerebellum, so many signs are there. Yesterday's case, did you get the olivary nucleus, dentate nucleus, olivary nucleus, big headache? Just say coordination. Titubation, skull and spine, no gibbous, no spine tenderness, meningeal signs. Don't say absent. You can't do neck flexion. You just do slate rack racing. Then what is SB3?
Sorry, sir. That's a single breath count, sir. That is 26.
Single breath count. 1, 2, 3, 4, 5, 6, 7. You're trying to say
Diaphragm.
Other systems, no. Okay. So the things you could not do, both things you must say. Stance and gait, I did not do. Where is it?
I did not mention.
You must write.
Yes,
I
sir.
could not do stance. I could not do gait. Okay. Next. Organomegaly. Okay. Now you're coming to what? Okay. All this is fine. Next. Where is Horner's?
Sir, I have not mentioned it, sir.
I would have given you D plus. No, if you have not checked your Horner's, you said I have checked. Next. Highest level is what? Vertical locali. Very good. The style is good. The style is good. Highest level is motor level is C2. How?
Sir, she's
How can you say motor level is C2?
neck flexion and extension. She's actually able to do it.
Checked. How you checked?
She's able to do it, sir, but it's
You
weak.
can't- First of all, she's had surgery. Just say above 5. Sensory level
Above C4 because at the acromioclavicular joint.
above 5. C5.
Yes, sir.
A reflex level, we ruled out trapezius. Above C5.
Sir.
Now I'm not sure, is it at C5 or above C5? This much is enough for the undergraduate level or postgraduate level. Okay, because I don't want to flex her neck and other things just now, post-operative thing, etc. So now, very good, vertical localization. Okay, is it a single lesion or multiple lesion?
Single lesions. I'm thinking of a single lesion.
Okay, now we are coming about vertical localization of what? Cord or vertebra? What is this vertical localization he's talking about?
Cords.
Cord or vertebra?
Cords.
Where? Cord. So sensory level is what?
Highest is
Reflex level above C5 is cord.
Yes, sir.
So vertical localization of the cord lesion is above C5. Sensory level of the what? Root.
Cord.
Motor level of the what? Root.
Root. Sir.
You understand?
Yes, sir.
So reflexes of other, you understand this?
Yes.
So when you say what structures are affected, cord and roots. Sensory root, why you're not, sensory root is there, cord is there. Or are you saying everything is cord?
Can't say that, sir.
You understand?
Yes, sir.
Otherwise, you're saying it is like a transverse myelitis at the level of the cord. Transverse myelopathy at the level of C5. That's not what you're saying. Okay. Then next.
Uh,
1 minute.
So the
Now you're going for
horizontal.
quadriparesis, anatomical localization. Now what next?
horizontal localization.
Go next. Next slide.
So I
You're
have,
saying it's compressive.
yes, sir.
Oh, take the history. So it's progressive, slowly progressive.
Yes.
Definite level is for what?
Sensory.
If just say motor, the sensory, all and reflex level are all converge upon one point, you will say single level, definite level. That is a cord, feature of a cord involvement. Okay, that is a asymmetrical pattern. Non-selective involvement of tracts. Don't sell yourself. Sequential involvement of tracts. Don't say. Which tract is sequentially involved?
So for her,
Corticospinal, only one tract. You understand? Again says what? No. What is the nature of your lesion? Is compressive lesion. One step before that is what? Extramedullary or medullary? If it is extramedullary, is it intradural or extradural?
sir.
Then extramedullary. You can start like this.
Yes, sir.
Asymmetric onset, motor neuron signs, more prominent, early, absence of dissociated. 1 minute. Against extramedullary lesion, what is for?
So the for is all the fact that it was asymmetric.
Onset
Yes, sir.
and progressive.
Late bladder.
That's all. You understand?
Yes.
And then you go on to, if it is extramedullary, is it extradural or intradural? Intradural, no, easier to sell extradural. Is there any pain and tenderness?
It's not this. Pain
So
tenderness
it's
is
not
not.
extradural. But if there's radicular pain, extradural. If there is pain and tenderness, extradural. You understand? So you say that whether it's extradural or not. I would go for extradural. Maybe, I don't know. You're right. Next level. Etiology. So compressive lesion.
Yes, sir.
So compressive lesion slowly progressing is what? Compressive lesion slowly progressing extradural is what? In the region of the most mobile region of the spinal cord. A, it is traumatic. What is traumatic? Disc lesion or a growth. If it is a growth, what is the common growth? Extramedullary. Is it a neurofibroma or is it a meningioma? Or is it an arthritis? That's the compressive lesion. So your compressive lesion are three. Traumatic as a result of disc, tumor as a result of neurofibroma, inflammatory as a result of arthritis. You decide now. It's not vascular.
It's not so.
There may be secondary vascular phenomenon. It's not metabolic.
Yes.
You understand? It's not immunological, unless you say arthritis. It's not metabolic. Sorry, it's not degenerative. You understand? So next lesion, next slide.
It's the same thing, sir. The compressive extramedullary intradural. Yes, sir. The same thing that.
Absence
Sorry, sir. One second.
of what? What is it you're thinking?
Just the summarizing the horizontal localization. Compressive extramedullary intradural is what I was thinking of, sir. Then etiologies for that I just want.
Schwannoma, neurofibroma, AV malformation. You got through it?
No, sir. I didn't look for a.
Meningioma, schwannoma. Why not this?
I was thinking of an intradural more than that's.
Why you want to think of intradural? Doesn't matter. Extramedullary. Okay, okay. I agree with you. So there is no evidence of any spinal lesion. Therefore, I thought in terms of intra.
A couple of thoughts. One, you said, just to take you back, I didn't understand what you were trying to say when you said the perianal sensory loss. There was no perianal sensory loss.
Yeah, I had checked for sensation, sir, around the. She was able to. I mean, she was answering when we had.
So is the and then you said that there is no suspended loss as well, is it?
Yes, sir. That considering points for an extramedullary lesion.
No, so if you have a patient who's got sensory, because go back to your slide of the sensory level, the one after, no,
Which one, sir?
no, the one after that, the last one, yeah. Sensory level above C4,
Yes.
if there is preserved perianal sensations, what are you trying to say? Did you get my point?
I see, yes, sir. That's not fitting. The fact that sacral sensations were
No, what
spared.
you're trying to say probably is that the sacral sensation is not disproportionately lost. It is the same as everything else. It has to be the same, right?
Yes. Yeah,
Otherwise, you're saying that she's got a suspended loss.
Yes, sir. It's
If
not.
you say that the perianal sensations are completely preserved, that's one point. Second is, when did she stop walking?
This was she was able to walk on her own till no, she was able to walk with the help of one person somewhere around September 2023, last year.
So, and from your examination, what seems to be the dominant thing which is involved? Even though history was all motor, from your examination, what you seem to have shown us is that the proprioceptive sensory impairment was the dominant problem, and that's probably the reason why she is not able to walk. Like sir pointed out, that despite the strength that she has, if she has 4 on one side, that can still compensate for a 2 at the hip on the other side, and she should have been able to walk. But if she has such severe proprioceptive sensory impairment, that becomes significant. In which case, then, if you're thinking of an intradural, where would you think the intradural is? What is the typical presentation of intradural lesions? Meningiomas versus neurofibromas. Neurofibromas more in women, more cervical. Meningiomas, thoracic. So what is the usual presentation? Is usually anterolateral, and that's when they have the typical presentation and go on for months together, 8 to 15 months with unilateral findings, very late bladder involvement. But if you have it's something which is compressing from posteriorly, then you could possibly have a presentation like this if you're thinking of an intradural lesion.
Yeah. So he has done extremely well. 8 on 10 for history. 8 on 10 for finding, because it is making sense. There is correlation in what he is saying. So I will give him 8 on 10 for history. Now his diagnosis synthesis is okay. He's got it reasonably correct. It's not a, he cannot, you know, it's okay. I can give him 7 on 10 or 8 on 10. Now I want to give him something for physical examination. I can choose anything from to ask him to do a clinical examination, but you have to be fair. You cannot ask, please do this finger nose test, you please do this. No. Where he made the error. Why did he say jaw jerk is exaggerated? I want to give him good. I want to convince my partner also to give him good marks. So I want to show off that he knows. So I want to ask you, how did you do jaw jerk? Now you do jaw jerk for me. How you do jaw jerk? Hammer. Very, very hammer. Okay. क्या कैसा करेंगे करो जाओ जाओ jaw, jug.
Partially open your,
Huh?
partially open your.
Partially open. He's asking me partially open. Okay, no. Partially open. And what are you doing? Through my beard, yeah, go ahead.
And
Ah, okay. What you're watching for?
the masita.
What you should do is, sorry, place your hand on the masseter. You understand? Because this is the effector muscle. Mentis is your other muscle. You understand? You have to feel the masseter. Okay, fine. Now, did you do along with the jaw jerk? You said exaggerated. No. Either may not exaggerated. But if you had said exaggerated, do the snout. Not for me. We might find positive for her. How do you do the snout? That means you will say exaggerated and is above. How will you do? Snout. How do you do? Then snout is like this, na? So put your finger. No.
Sir, I'm not.
Okay, mine is positive, I can make it positive. Understand? Then you have to do all that. Then you say, now, second thing I may ask is, how do you do the Babinski? Sharp or blunt, or which object you take? Sharp or blunt? Okay. Key is blunt. Okay. Or you fix the ankle or you fix the foot? What do you fix? Ankle or the foot? The ankle participates in the Babinski. So fix the foot. No, why your ankle don't touch? Okay, Babinski, it is the first movement that occurs at the metacarpophalangeal joint, which is going up. Then you said something about sensation, vibration sense. You said it is diminished, both sides. Okay. Yeah.
The comparison.
Don't compare. We don't worry about comparison. We are just saying it is there. And then temperature also you have said. Okay. Now bladder, you have to feel the abdomen and then say bladder is not there. Okay. Anything else you want?
Yeah, you just want to show the joint positions of the elbow.
आंख बंद करके ऊपर ये आपको दिखाना है कि ऊपर है या नीचे है, ठीक है? इधर है. फर्स्ट व्हाट इज ऊपर एंड नीचे. माँ जी देखिए, एक सेकेंड आंख खोलिए. अगर ये नीचे है और ये सीधा है, हाँ नीचे है सीधा है, हाँ अभी आंख बंद कर दीजिए. अभी कैसा है? अभी
So you have done very well. Okay. Thank you. Thank you. So he has got a history, he's got a physical finding, he's got this examination, observation, interpretation, synthesis. Very good. That's all we're looking for in the exam hall. Okay. So you will surely pass, but whether you will pass with a high grade is subject, or how you have written the history sheet. If there is a lot of kacha-mucha, scratching, this thing, that thing, whatever marks he has got will be minus. Neatly you must write. Okay. And if you say, sir, I couldn't, but I didn't, but I never, but I thought, but, and don't write diagnosis, minus. Sir, I came late, sir, I went there, patient was not Never ever say patient is not cooperative. Sir is the most cooperative patient, even if he's the disobedient person. Okay, these are all the things that your behavior characterize. Correct.
What's a
Very
D plus?
appreciate.
What's a D plus?
D plus is Matai score. D for Matai. Okay, very good, very good. Mama? Thanks, always thank the patient. Okay, right, thank the patient. Because he's the. What? What? She's actually. Sorry, sir is asking what is the social, the economic status of the patient?
Yes, sir. Yes, sir. So the illness, yes, sir. She used to work as a
That's a
house.
very pertinent question because the affordability of the treatment.
Yes. Yes.
Check. Check. Check.
She was almost falling down in her sleep. So what is the impact? How many children?
Yeah.
What
That
is
because
so
the-
these
these
are
are-
all not, are there clinicians concerned? I don't know.
But,
Yeah.
but
So it will add, probably it will add your,
he wants to answer. Go ahead.
probably it will add your social consciousness and it will may impress your examiner.
So she works as a housemaid.
well.
She works as a housemaid prior to this. The illness has impacted her in the sense that because of her illness, her husband has left her. She has two children. Her daughter is in 11th standard and there's another daughter in 8th. And their exams, she actually has her exam in December and they're forced to be here because of the.
Took everything, but adding something should have made it very, very socially acceptable physician kind of person.
But that's true, you know, but because it is surgical, really, the cost, you must even do it free. I would even go to the extent if the patient says, I have no money, CMC must do it free. If you don't do it free, who else will do it
How
free?
did she raise the money for this patient?
But if it was a secondary deposit, not.
Now, how much money will be involved in the care totally?
How much money will the
Will
cost be? How much will the charge be? I don't know.
No, no, what is the kind
How
of,
much will it cost?
Enter the theater, it will be 1.5.
1.5.
Just entering the theater.
1.5.
so,
Our
how,
salaries are low, so.
how much will she raise up? And the subsidy from CMC, what is it going to be?
They are actually from West Bengal, but they stay in Ludhiana.
Must look at it, you know, but she's coming all the way from Punjab to Vellore. With what in her mind? Faith, hope that they will do a good job here. If she has not gone to any hospital there, I don't know. It's unusual. So that's why I'm saying they are your best ambassadors. Look after them properly. You know, they will bring you back more patients if you want. If you don't want patients, you discharge them and rehab, etc. So any doubt, any question in the way in which we approach the problem? Okay. Anything that is deeply concerning you? So this approach was not there. Did you have any different diagnosis? Okay, because if it is a high cord lesion, okay, I just want to end by saying, I know it is above C5. I don't know if it is high cord. C2, I have to shave the hair and check for the sensations in the C1 territory. Don't go to that level. So just say above C5. Okay?
I'll just make an announcement. We will cut down on the short case presentation for today in need of time, and we'll start the case report presentations in. We'll start the poster presentations now, and we'll have a case report presentation in CK Job Hall and case series and original reports in Jacob Chandy Hall right over here, so you can stay. I'll just tell you the judges. Yes. I'll just hand over the mic to Dr. Mercer. We'll have the so we've split the participants into two groups. So I'll read out a few names. So those of you will be here, and the rest of you can go to the other hall. Dr. Jonathan, Dr. Samartha, Dr. Rakesh, Dr. Berilini, Dr. Mercy, Dr. Sai Supriya, Priyanjali, Tangamani, Sivaranjani, Lakshmi, Ritesh, Krupa, Priyanjali, and Anita. So all of you can remain here. The rest of you have your presentations in the other hall. Can I request Dr. Dilip Mata and Dr. Kurian Thomas to judge the competition here, and Dr. Seshadri and Dr. Vivek Matthew sir to judge the competition in the other hall. So general instructions.
What I'm saying is upstairs how many?
There are, that's why there's 20.
There are 20, and here we have 14. And both of us are going to listen to 14.
That's a safe here, no? There.
Just one question.
One question.
Just one question. In the interest of time.
No. This is what? This is paper presentation.
It's effectively an hospital.
It's a e-poster presentation, sir. We are modeling it similar to the 3-minute thesis competition, which is usually held in the clinical epidemiology, where they get 3 minutes to speak and explain their study. The catch is
One
they-
question, anyway, leave it. So how many? 14 people, and how much? This is 7 o'clock, 1 hour. I can finish it. Well, if it takes 5 minutes. Okay.
150 divided by 5 minutes.
5 minutes, that should be enough. So we won't fix it into one question. Some may be more, some may be less. I need I don't have it.
So I assume the order of presentation has been sent to all of you. So this presentation is an auto run. So you will all be given 3 minutes of one static slide to present. Follow that, you have 1 minute for questions. And then, so can you all sit in the order that was sent to you, or I can read it out if you're not sure. Okay, participant 1 will be Dr. Jonathan.
Can you all sit in that order so it's easy? Dr. Samartha,
I think it has
Dr. Rakesh,
conclusion.
Dr. Beryl. Just to familiarize yourself with this order, Dr. Mercy, Dr. Sai Supriya. Okay, Dr. Priyanjali, Dr. Tangamani, Shivaranjani, Lakshmi, Ritesh, Krupa, Priyanjali, and Dr. Anita in this order. So 1 minute for questions.
This is in this order?